So let's start with the presentation today.
Yes, sir.
All right. So abdominal aortic aneurysm, or AAA, is a localized enlargement of the abdominal aorta. Of the abdominal aorta, such as the diameter is greater than 3 centimeter or more than 50% larger than the normal aorta. The word aneurysm is Greek word aneurysma, that is for widening. The first written evidences of AAA is recorded in the Book of Hearts from the Eber scrolls of ancient Egypt dating back to 1550 BC. So it's quite an old disease and we know it for a pretty long time. Now this stated that only magic can cure tumors of the artery. And Indians have contributed significantly in identifying the disease as well, like India's Susruta 800 BC mentions that aneurysm or granthi in chapter 17 of his great medical text, that is Susruta Samhita. He said similar sentiment to the Egyptian, where he wrote that a granthi can be cured only with the greatest difficulties. How these aneurysms are classified? Now, basically, we understand the aneurysm is dilatation of the aorta, and we classify according to the location of these aneurysms. So, this aneurysm can be there in the aortic root, or they can be in the sinus of Valsalva. In thoracic region, this can be in ascending aortic or descending aorta. Abdominal aortic aneurysm, or AAA, they are present in the infernal aorta. And then thoracoabdominal aortic aneurysms are more challenging again. They comprise some of all the aorta in both in chest and abdomen. Now this is how the aortic root aneurysms look like. They involve the origin of the coronary and they involve the root of the aorta right from the beginning. And this is the sinus of Valsalva aneurysm. On the right side, if you just can see, there is aneurysmal dilatation of the sinus of Valsalva. And of course, this arch, we can have an aneurysm in the ascending, arch, descending, or involving all together. So basically, to sum up, these are the aneurysm that location that we can have in the sinus of Valsalva or in the root of the aorta, the ascending aorta, the arch and the descending aorta, and then thoracoabdominal aortic aneurysm, and then AAA. So these are the location of the aneurysm that we see in when we are dealing with abdominal or thoracic or any kind of aneurysm in the aorta. Now, how do they present? Mostly, intact aortic aneurysm do not produce a symptom. As they enlarge, symptoms such as abdominal pain and back pain may develop. Compression of the nerve roots may cause leg pain or numbness. Untreated aneurysms tend to become progressively larger, although the rate of enlargement is unpredictable for any individual. Rarely, clotted blood, which lines most aortic aneurysm, can break off and result in an embolus. Prevalence of AAA is 4.8% in men aged 65 to 69 years of age, rising to 10.8% in those aged 80 years or over. The mortality from unruptured AAA is very high, approximately 80%, whilst aneurysm-related mortality of surgically treated asymptomatic AAA is around 5%. So there is a significant difference when we diagnose this aneurysms, especially the AAA, before it got ruptured, then we can do a fantastic job. But once it is ruptured, then the outcomes are dangerous. AAA makes up to 2.4% of the burden of cardiovascular diseases ahead of hypertension and valvular disease. That's what we are talking about. It's not a rare disease. It's just that we don't look for it, and the time you look for it or the time you find it's already bled and they have, we have lost our life, or sometimes they come in a very critical condition where we are hardly able to do something. So we must be looking for this aneurysm. Now, in which patient we should be looking for, and who are the risk, who are at risk of developing aortic aneurysm? Once we know that, then we should direct our screening towards such patients. Number one is the smokers, who are at highest risk of having this disease. And once there is a family history of abdominal aortic aneurysm, thoracic aortic aneurysm, then there is a propensity of the family member to have more of them. Patients having coronary artery disease are at higher risk of having aortic aneurysm. Hypercholesterolemia, cerebrovascular disease, collagen vascular disorder, peripheral arterial diseases are more commonly associated with these diseases, especially because we do a lot of peripheral arterial disease intervention. We see quite a correlation between these two diseases, and we get them a lot in those patients. The surgical management of AAA dates back over 3,000 years and have evolved greatly since its conception. It started with crude ligation and went on to open repair, and then went ahead with endovascular aneurysm repair, which is a fantastic way of looking at treatment of abdominal aortic aneurysm or thoracic aortic aneurysm per se. So it started with ligation, then it went ahead with anastomosis, and biological graft came in, then synthetic grafts, and then more modern day open surgery. And then we have fantastic imaging like CT angiogram, which can exactly tell us the size, location, and the vessels coming out of this aneurysm. And then we can plan our EVAR. That is how this evolution of the therapy has happened. The advent of successful open surgical repair of AAA using synthetic graft in the 1950s proved to be the first definitive treatment of AAA. However, the procedure remained highly invasive and many patients were excluded due to medical and anatomical contraindications. The parodies work with Pamaz and Hector Baron in the late 1980s aimed to rectify these issues. Parody developed the first catheter-based approach, arterial approach to AAA intervention, which is a very, very significant milestone for developing this present-day endovascular therapy. The first successful EVAR was completed by Parody in Argentina, September 1990. So we are already 30 years old in this therapy. And this aneurysm, the aneurysm was approached intravascularly via femoral cut down. The restoration of normal luminal blood flow was achieved with the deployment of background gap mounted in the Pima stent. There was no need for aortic cross clamping or major abdominal surgery, which were the risk factor increasing the morbidity and mortality otherwise. So we have traveled a long way from Sushrita to Pamas, and basically this is how we do. There is an abdominal aortic aneurysm. We just put a graft. This is the main body of the graft, and then we take a side graft, and then we just go ahead and occlude this aneurysm like that. Let's look at a few examples to understand it better. So elderly lady, pain abdomen, and history of fracture of the hip. So she presented to us with continuous pain, and we did CT angio, then followed by we did a catheter angiogram where we can see there is an aneurysm in the abdominal aortic aneurysm. And these are one of the safest of the aneurysm because you have a very good landing zone. Renal arteries are very well high up. So you have a beautiful landing zone over here, and you can put your graft and you can go to get a nice anchor, because again, the aortic bifurcation is far below this aneurysm. So we have a good landing zone on either proximal and the distal side. So this is what we did. So we just had a cut down on the right side, and then we had a percutaneous approach from the left side, and then we put our pigtail and we checked everything. We looked at the aneurysm, and then we took our graft and we deployed the graft, and you can see the site of the aneurysm. This aneurysm is completely gone over here, and this is beautiful. And this is the simplest form where you don't have to do a lot of reconstruction. Now let's look at the next example. He is a 65 man. He's a non-smoker but diabetic, hypertensive. He presented the progressively increasing pain abdomen. And this is a CT angiogram which is showing abdominal aortic aneurysm again. And there is a stenosis over the common iliac artery on the left side, which has to be dilated. We took a percutaneous approach from the left side and then did a little bit of balloon dilatation, and then went ahead. And this is the angiogram which is showing this aneurysm over here. This is stenosis. And then we went ahead and deployed the main body of the graft. So this is the graft where you can take the main body. This main body will have aortic component and then iliac component. And once we have deployed that, then we have, this is open over here. So we just have to cannulate, and there are many techniques to cannulate and to confirm whether you are in the in this particular true lumen or not. And we went ahead and we cannulated and deployed the limb. And once you have deployed the limb, this is the main body, and this is the extension of the main body, and this is the limb which has just been deployed, and this is a good apposition, and this is how it looks like. The aneurysm is completely excluded from the circulation. So now let's look at the next example. He's a 75-year-old man presented with massive hemoptysis, known case of tuberculosis in the past. Patients were referred to me for bronchial artery embolization. Now I did a bronchial artery angiogram, but there was no abnormal blast found. And I said that there is no abnormal blast. I just informed to my respiratory physician and I stopped the procedure. So this was in the evening, and the next morning, the patient got a massive hemoptysis, and patient was in shock and shifted to ICU. And immediately we just moved the patient to the cath lab. What was happening is that we did a Ct angiogram immediately, and then we found there is an aortobronchial fistula. So there is an opening of the aorta into the bronchus, and there is a flap valve-like mechanism. So when the patient is coughing a lot, then this valve opens up and a gush of blood from the aorta is going into the bronchus, and he just coughs out, and then temporarily it just stops. And once again the patient have a bout of cough, then this is what is happening, and every bout is more than about a liter. So the second bout, he got into shock, and we shifted the patient into the cath lab. Again, as I said, we have to take a percutaneous approach from the one side for control angiogram and all that. We expose the groin. Nowadays we don't have to expose the groin. We have ways to do it without exposing the groin, but this is also a simple arteriotomy where we expose the groin and we expose the femoral artery, and then we just put a sheath, and then we took our graft, and then this is our control. And once we do the angiogram, we found that this is the aortobronchial fistula. This is where the leak is. We can see this very clear round thing. This is like valve-like mechanism. The aorta is opening into the bronchus over here. And then we just deployed our graft, the thoracic aorta, at the level of the fistula. And this is the patient getting discharged after 10 days. So now this is a rare case. So we just got it published as well in 2010. Now let's look at the next case. He's a 65-year-old man who is a smoker and bronchiectasis, known case of bronchiectasis, presented with massive hemoptysis, and he's not fit for general anesthesia. A CT angiogram was done, which is showing there is a thoracic aortic aneurysm. So very interesting story. I was just called, I was in Delhi, and then I just have to rush to see this patient in Bhubaneswar, and they said that the anesthetist said that we cannot give general anesthesia, and the cardiologist said that we have triple vessel disease, so it's very difficult to give a cardiac clearance. So we were discussing a lot, and then I discussed with the patient relatives that we just have to do it, because once we lose the patient, once the aneurysm bleeds again, then we lose everything. We don't have much to do. So we did this case under local anesthesia, and we just, as usual, we just opened the groin and took the graft, and we just deployed the graft across this aneurysm, and you can see that this is the level of the aneurysm, and this is completely gone after deploying the graft, and this is the angiogram post graft. So you can see this is the level of the aneurysm, and this is the angiogram post deployment, where we can see that aneurysm is completely excluded from the circulation. So let's look at the next case. The young man met with an accident with a blunt trauma, chest and abdomen, presented with a massive bout of blood vomiting, shifted from AIMS Bhubaneswar to Visakhapatnam to my center, and the patient reached by 3 p.m. and we quickly ran a CT angiogram, and the CT angiogram is showing that there is an injury to thoracic aorta, and there is a pseudoaneurysm. There is active leak, and there is a lot of thrombus around, which is holding up at this point of time. And this is an emergency where we just have to rush in and do it. This is on 4th of July. We have done this case 2019, and this is 3:49 p.m. Immediately patient reached, and we did the CT angiogram. We found that there is a transection of the aorta, and immediately we shifted the patient to cath lab, and we did this angiogram, which is showing that there's a profuse leak from the thoracic aorta, active leak. It's just that there is some thrombus around, so it's contained a leak, but it is very dangerous. And This is a transection of the thoracic aorta, and we decided to go ahead and treat it. This is about by 9 o'clock in the evening. We were there, and then this is the transection of the aorta, and this is our measurement, and this is the we have this pigtail over there, and this we measure to put the stent graft over there, and then this is our graft. So by 9:26 we are done with our graft, and we can see that the leak is completely sealed, and this life could be saved. Otherwise, these are very, very dangerous disease that can kill within hours. So this is the transection of the aorta with the bleeding, and this is post stent graft. Let's look at this one more example. This is again more complex situation where this is an elderly male, and patient presented with sudden onset of breathlessness and very high creatinine and cold left lower limb. He presented to a hospital in Kolkata. He's a middle-aged, almost like 55 years old, and he presented with all this complaint at Calcutta, and then the patient, they suggested that we should go with the amputation of the left lower limb because there is no blood flow to the left lower limb. Hence, we should go ahead and do an amputation. Patient didn't agree, and patient was flown from Kolkata to my center because some of their relatives have operated. So they said that we will go ahead, and they flew from Calcutta to Visakhapatnam air ambulance. And so what we did is, once we did a CT angiogram, we found that there is a type B dissection of this aortic arch. So we attempted to go ahead and try to do endovascular repair. So first, to understand what is happening, we tried to do an angiogram, and which was difficult, it was very, very much impossible to just do an angiogram in this patient. Why this limb is cold? We didn't get much information from the CT angio. We got some, but we thought we'll do a catheter angiogram before we plan our treatment. A right common femoral arterial approach, we are always getting into the false lumen. When I tried from the left common femoral artery, the true lumen, but impossible to go beyond thoracic aorta. So the right side, it just goes all the way to the aortic bifurcation, not beyond that. The left common femoral artery, it goes to the thoracic aorta, but I'm not able to go beyond that. Then what I did is that I took the left radial and then came down towards the arch, and then looked at the false lumen, and I tried to go towards the true lumen in the leg. Let's look at this angiogram that we have obtained during treatment of this patient. So here I'm just going from the right side. I'm able to go up to this, but not beyond that. When I'm going through the left side, I'm just able to go up to some distance, but I can understand that it's into a false lumen because I'm not able to rotate my pigtail catheter. So, this looks impossible. And then I try to just do a check angiogram, which is showing me the SMA and bilateral renal artery. So, and this is the false lumen. When I'm trying to come down from the left radial down. So let's look at it. So I just approached from the left radial and then just came down. Instead of going towards the thoracic and abdominal aorta, I went into the ascending, and then I could see the true lumen. And so then what we did is that we just came from the radial, and then we dropped ourselves from the radial into the true lumen, and then from there we went inside the true lumen and did the injection. We found everything okay. So what we did is we plan to do a DVASC. This is actually post DVASC picture. So we decided that we will put a graft, just a Y graft, so one which is going from the ascending aorta, and then one arm of the Y going into this brachiocephalic over here, just connect into the brachiocephalic. The other one we just connect into the left carotid, and then we just go ahead and we treat this, and then we will see if required we can do a occlusion of the subclavian artery. So our purpose is that we will put a graft right from, because this is where the dissection starts. So we will start putting our graft from here. So because we will start putting our graft from here, so what we decided is that we will just put a bypass over there. So we did a debranching basically, So this is how the debranching graft. So the day one, what we did is that we took a Y graft and we just connected the lower limb of the Y into the ascending aorta, and the second limb into the brachiocephalic, and the third limb into the common carotid artery. And once we have done that, then we deployed a graft, which is just coming over here. Then we deploy the complete graft over there. We can see the root of the aorta looking okay, ascending aorta looking okay, and the coronary artery, left and right coronary artery, and our graft is very well patterned, very well nicely flowing over there. And then we just put our graft over there, and then we could see that the flow is beautifully over there, and then slowly this aorta, the true lumen, is opening up, the false lumen is getting compressed, and the patient did well, stayed with us for about a month time and did well. He came back for a follow-up, and this is the follow-up CT angiogram, which is showing absolutely fine. He is clinically absolutely fine, and of course we got a high aortic bifurcation, but rest of the things are fantastic, and he has absolutely no symptoms whatsoever. So in conclusion, the journey towards truly effective treatment for aortic aneurysm has been a long and experimental one. Once regarded as one of the most deadliest pathology with a little chance of favorable surgical outcome, aortic aneurysm can now be successfully treated with minimally invasive procedure. And of course, Sushruta's millennium-old warning was worked often well over the years, and thankfully today we have a highly effective and safe therapy for aortic aneurysm. Thank you very much. Satya, over to you.
Sir, thanks a lot. Like that was like a very nice, very like no summary.
I didn't want to make it long actually.
No, it was good. Like no, so it covered almost all the points. Now the forum is open for the questions. I can either unmute you if you have a question. I can unmute you, or you can even chat in the question box.
They can unmute themselves and ask questions.
Right. I can. Yeah.
Do you
I
have
can
that
allow
option?
them. Yeah, I can allow them actually.
Yes.
Yeah. So now you want, like, you can unmute yourself and like ask the question. So one of the couple of questions like which has come earlier was this: with the patient presenting with common symptoms like pain or breathlessness, how is it possible to differentiate an aneurysm case?
Basically, suppose a patient comes with breathlessness, we just go ahead with our routine investigation, like, any respiratory symptoms or a cardiac symptom. And, if the common symptoms, the common pathologies are excluded, then we can always do a CT angiogram, which is the very simplest of the investigation available to us, and it can give a precise diagnosis. CT angiogram is very, very sensitive. We can do it, but we just don't do it for any patient who comes with breathlessness, because breathlessness is such a symptom. Like an asthmatic can have breathlessness, and pneumonia case can have breathlessness, a heart attack can have breathlessness. So obviously we go from the common towards uncommon symptom as we investigate them. So
Right.
once you see a patient, we'll definitely able to understand. You look at the SpO2, you look at the blood parameter, and of course, you look at the ECG, echo, and all this. Then you can always diagnose. It's a cardiac problem, or it's a respiratory problem, it's a general problem, or it's a. If nothing is there, obviously we can think of aortic problem, and we can do a CT angio.
Right, sir. And is there a scorecard, like something like a CHAT score or something like to identify the logarithm through a paper, like chance of risk of in a patient?
I am not aware whether there is some scoring. If you have this, then the score, then
Correct.
the risk of having aneurysm is high. I am not aware of such thing. Satya,
Okay.
you are aware? You have something
No,
from your company?
I'm not aware. Like, no, I'm just like asking, like that came wrap, because in many other therapies we see this, like, no, they come up with an algorithm where you can identify or like
We should actually.
Yeah. So
Actually, we can work out on that. Yes.
Okay.
Suppose you have peripheral arterial disease, we can
Correct.
give to something. If you have
Right.
hypercholesterolemia, you can give one.
So
Nice.
something like that
Actually,
would be given to the diagnostic
Metronics has come up with a proposal to me that any patient who is coming to the cath lab for a coronary angio or a peripheral arterial disease for intervention or a carotid artery disease stenting, then we should have these questionnaires to fill up.
Right. Okay. Okay.
Whether they are a smoker, give 1 score. Whether they're hypercholesterolemia, 1 score. Aneurysm
Right.
in the family, 1 score. Peripheral arterial disease, we can work out. We can work on this.
Right. So
Now
some
that we
kind
are
of
closely
analysis.
associated, let's do it. Yes.
Right. And what percentage of the cases can be corrected only through a surgical, or most of the cases are can be handled through the intervention routes?
So now there are 3 types of therapy: the pure surgery, hybrid, and endovascular.
Right, sir.
Now endovascular can manage 70% of the cases, endovascular alone.
Okay. Okay.
And 20% we will need a hybrid, 10% only surgery can do, especially the root of the aorta and the sinus of Valsalva and ascending arch. This goes for surgery. And as you come up a little bit, then it is a hybrid, and then you come down, then it is endovascular.
Okay, sir. Okay. Thank you.
Simple.
Sir, this is Angeline. I have one question, sir.
Yes, please.
When there is a possible of stent graft fracture, metal fatigue,
Sorry?
like when there is a possible of stent graft fracture is happening, sometimes the metal fatigue we say no, so that kind of
Yes.
case.
See,
is that okay?
Tell me, Angelina. You can go ahead. You can complete
sir.
your question.
Is that even aortic pressure should be maintained in that time after the graft deployed? And is there any other reason?
Fracture of the aortic stent graft are uncommon, and they are not seen immediately. They are a symptom which is seen after a long time after you have deployed the graft. It is not an instant that the fracture is ruptured, the stent graft has ruptured, the metallic things are ruptured, or the PTFA membrane is ruptured. That's very uncommonly seen actually. But the reasons why it is uncommonly it can happen because of raised blood pressure, or because you have traumatized, and sometimes we try to fenestrate and you put a wire somewhere and you can rupture one of those grafts and all. But per se, due to high blood pressure, it is ruptured. Is very, very rare actually. Have you come across with such cases, Angelina?
Sir, we have come across a couple of cases, across, okay. And then like that, and that's common with all the graft, as you rightly said, like more to do with the patient anatomy, and probably at the end of the case, like you procedure, you also like you have you get a sense that like if the graft is
you can. It is never a diagnostic dilemma.
Right.
But once you have little experience of doing it, those things are very, very rare actually.
Correct.
Because the first thing, what is the success mantra in doing all this is, first is that you study your CT angiogram well. Once you have seen your CT well, the second thing comes that your planning should be perfect. And once that has happened, then execution becomes easy. The most of the time you land into a problem when your planning is not proper. You have not seen the CT casually, you just go and try to deploy something. Obviously, you will have all sorts of this kind of problem.
True.
And second thing, if you are trying to just have trying to do a graft on a highly calcified vessel, then also you have stent fractures.
Okay.
Sir, sir, if the aneurysm involves sinus of Valsalva, is endovascular treatment is an option, or a surgical would be a preferred?
It is not an option. You have to go for surgery.
So one question. Actually, when we were talking about pain and breathlessness as a symptom of aneurysm in the aortic, normally doctors relate it to the cardiac or the respiratory, and when they relate it to the cardiac, they go for ECG. If at all something is not coming in the ECG, maybe Holter or something, they relate to the arrhythmias. Is there any kind of difference between the arrhythmic breathlessness and pain and as compared to the aneurysm?
See, aneurysm patients who are presenting with breathlessness because of cardiac origin and all, they will definitely have ECG changes, and you can see all the troponin T and all those enzymes you can do, and you can see elevated enzyme levels. There is no doubt about it. You cannot have a cardiac patient who is having an ongoing MI or who had an MI and presenting with breathlessness who doesn't have a ECG change. But in an aortic dissection, you don't have ECG changes. So that is the first diagnosis. And respiratory, most of the respiratory cases, once we have breathlessness, we do a pulmonary function test or a chest CT. So once we do that, obviously we see a dissection very clearly on a chest CT. And of course, if there is a pneumonia and all other respiratory symptoms, we can diagnose that as well through a chest CT. So in a good center, average to good center, it is not missed. Any patient who comes with breathlessness, if the first thing is that we exclude the cardiac causes, and then we look for the respiratory causes. As we look for the respiratory causes, we will always, as we do a CT will tell us that there is a dissection. So it's not missed on.
So CT is a part of protocol only.
Yes.
Right. And sir, one more question was there, like for the ICDs and all those stuff, what we used to do is we used to develop the market, making more awareness and access to the therapy. We used to go and meet the primary physician, because most of these patients were missed there itself. So like we came up with like post-MI patient with low EF. So that was a class 1A indication. But then as though there would be a lot of patient who will be eligible for ICD. So what they did was they said, okay, if you have a post-MI patient with low ejection fraction, at least do a Holter. And then if Holter also suggests, then this patient becomes very, very important for the ICD implantation or something. Can we go to a primary physician and make him aware about AAA or something like that?
That is what we were discussing now. So what we can do is that we can have a scorecard. So we can give the scorecard, like if someone is more than 60 years of age, please fill up the scorecard. Age more than 60, you take it. Now then he's a smoker, you take it. Then he has coronary artery disease, you can do a tick. He has peripheral arterial disease for which he has some intervention done or he's on medication, you take it. He has a MI. So these are the risk factor for having, or he has pain abdomen or having chronic pain abdomen. So then we can actually guide them that this patient might have something like that. A simple ultrasound abdomen can tell us whether there is a AAA or not. And of course, for the thoracic and arts, there are other symptoms and like breathlessness, we can plan it actually.
I think, sir, like this is where like we will take your help. If you can help us to develop an algorithm, and once you develop an algorithm, even the system and the AI can pick it up. Like now the newer things, like the most of like the time, current AI systems just can work through the algorithm. So if we have this algorithm specifically with the cost,
absolutely
right. I think like we will require your help.
We'll work on that.
Right, sir. Right.
Yes, we will do it.
Sir, actually, I have a question, sir. This is Jay Prabhu from Lifetech. Sir, actually, my doubt is on retrograde flow, sir. If you are blocking the subclavian, or in the AAA, if you are blocking the internal iliac, so it is mandatory to block the internal iliac with the plug or coils, anything, or simply we can leave it.
If you have an aneurysm which is extending beyond the aortic bifurcation into the iliacs, then you can only seal it when you have sealed the internal iliac artery well. If you have left the internal iliac just with the graft just going over it, then there will be a backflow going into, and then there'll be a endoleak. So if you have an aneurysm which is extending into the iliac artery, then obviously you have to occlude the internal iliac artery with coils or plug.
Okay, sir.
But most of the cases that we do, it will have unilateral involvement. The other side will be relatively okay. So, you can just occlude one side, the other side, unilateral internal iliac artery will be good enough for, managing those erectile dysfunction, or in a female to supply the pelvis. That's good enough.
So we should not block both of the internal. Am I right, sir?
Ideally, we should not. Yes.
Okay.
But in case of patients who are coming with the hemorrhagic cystitis because of radiation and because of trauma, and they are not able to control the urologist, we have done internal iliac artery ligations, means embolization. So patient didn't have any symptom as such, but we don't recommend. They might have erectile dysfunction and other type of symptoms, which is otherwise called Eric syndrome. So we should not induce that. But if it is mandatory, you do it, because abdominal aortic aneurysm extending into bilateral iliac artery is a more dangerous disease than occluding internal iliac and causing some other symptom. You can always do internal iliac artery embolization without significant morbidity or mortality, but should be avoided for quality of life.
Okay, sir. Thank you. Thank you, sir.
Sir, any
So
kind of
Ravi,
patient.
you have a question?
Sir, I
Ravi
have a question.
Jaiswal. Usri, yeah, tell me.
Sir, I have a question. Any kind of patient awareness program will help to develop this therapy?
Sorry.
Patient awareness program will help to develop
Yes.
this.
Basically, for this we have to go in both way. We have to we have to create awareness among the physician as well as the public. So
Right.
in both forums we have to discuss, so that the awareness can be created, because this is a very, very important therapy. As we saw the statistics, if you just leave these patients and patient have a rupture, then 85% mortality rate. And if the patient comes without a rupture, treating them is about 5% mortality because of surgical or endovascular complications. So we have a huge benefit that we can offer to a patient by preventing a rupture of an aneurysm in the aorta. So definitely we should be aggressive on promoting this at the level of physician as well as patients. We can
Okay,
sit
sir.
down and make some strategy. You can also do that, and I can also help you whatever we can.
Right, sir.
Right, sir. Thanks.
I have, sir, I have
Hello.
one more
Yeah, Jai
question, sir.
Prabhu.
Yes, sir. So actually, recently we did
You can
one
ask all your questions.
yes, sir. Sir, actually, we did one replay case recently, sir.
Okay.
There is a small leak from the spinal artery, lumbar spinal artery. So, but it is not filling the aneurysm, sir. Aneurysm is not filling.
What
But
is
still,
spinal artery? Tell me first.
so it's a branch of artery supplying this from the aorta, supplying into the spinal cord, and it's not
See,
branch of artery, sir.
first of, let me just tell you.
Yes.
What is a spinal artery? Spine is basically supplied by an anterior spinal artery and a posterior spinal artery. They are very, very important, because if you occlude a spinal artery, patient will have paraplegia for life. So it's a very, very important thing. And the anterior spinal artery that we are talking about is actually so important, but it is so thin that mostly people can miss it. It is just like maybe 10 strands of hair. If you put together, how thick you see. In angiogram, we see anterior spinal artery is that much. Many of the beginner, when they do an angiogram, they cannot just demonstrate anterior spinal artery. It's a hairpin bend like structure. It just goes like this and take a turn and come down. So we call it as a hairpin bend like structure. That is called ASA, anterior spinal artery. It is very, very thin. It's a sub millimeter. It's like about 0.7 to 0.8 millimeter in diameter in most of the patients.
Okay.
We know anterior spinal artery so well because we treat a lot of spinal vascular malformations. So that is how anterior spinal artery is very, very delicate artery. Now you have a risk of occluding anterior spinal artery when you are treating a thoracic aortic aneurysm. In abdominal aortic aneurysm, you don't have such risk. What you're talking is that probably a lumbar artery has just opened up and you might be having a leak, not a spinal artery. The moment you say anterior spinal artery or a spinal artery, we mean that it is an artery of Adams-Kuvich. Artery of Adams-Kuvich will come from the thoracic level at the level of T9, T10, T8, mostly from the left side, less commonly from the right side. At the level of dorsal 8, 9 or 10, you will have this artery. You just do an angiogram, this artery, the lumbar artery or the dorsal artery will go like this. Anterior spinal artery in the proximal part of this dorsal artery, it will just take off like this and go and come down. very thin artery, like you can just Google it and see, just right anterospinal artery, you will just see the anatomy. So
Sure,
now when we are treating thoracic aortic aneurysm, what we do is that sometimes we just put a thoracic drain just to maintain the pressure, because once there is occlusion of the anterospinal artery, then you can have variation of pressure, increase of pressure. So we have to drain some of the CSF. That's what we practice for thoracic, but not for the abdominal aortic aneurysm. Now that you have a leak from the lumbar artery in the abdominal aortic aneurysm, if there's a small leak, you just observe. Sometimes they just resolve on its own. Otherwise, you have different methods to treat them. You know, we
Okay,
can just put a, we can do a percutaneous injection, inject glue or inject onyx, and we can catheterize those arteries, and we can just inject some microcoils. And that's another section where we can go for a second class sometime, how to manage complication or how to manage endo leaks. All this can be. I wanted to keep it as basic so that, we have a first interaction to discuss how things will be.
Thank you, sir. Thank you.
Hello, sir.
Yeah, please.
Sir, I'm Vinod Sharma from Delhi. Actually, I want to know, we have a case, there is innominate artery 50% occlusion, like stenosis in innominate artery, almost 50%. And carotid also in the aneurysm. It means 1.5 centimeter we have landing zone. So we need
The
to
left
put
carotid?
left carotid to innominate artery, almost 1.5 centimeter space.
Okay.
Okay, so how we are planning first, we need to bypass from innominate artery to carotid to subclavian, but in that case, that innominate artery not healthy properly. So what?
There are many different types of bypass we have done, and they are demonstrated and described in the literature. The first is you take one graft from the ascending aorta and you divide it into two. How do you do that? You just put a side branch. You just make a side hole and you stitch another graft to it. So it becomes a Y graft. So a single graft, center mein you made a side hole and you just stitch it outside. Just stitch it outside. Prepare the Y.
Okay,
so
sir.
the first graft, which is about, which will be around, we will take about a 10 millimeter graft. We will stitch it to that. So you take a side clamp onto the ascending aorta and put a side clamp, give a nick and make a small hole, and then you just fix it like that. And the first limb goes to the brachiocephalic. Now, even if there is a brachiocephalic stenosis at the origin, we don't mind because we are anyway bypassing that. So directly my flow is going from the ascending aorta to bypass. So I don't worry whether there is a stenosis over here or not. Even if there is a stenosis, good, there will be less backflow to us. But anyway, we will dissect it. We dissect it and we just stitch it up. Understood? So the first anastomotic, the first anastomosis is created from the ascending aorta to the one limb of the Y. And the second limb of the Y goes and sit on the brachiocephalic. Then we dissect the brachiocephalic and stitch it. Otherwise, what will have? There will be endo leak. There will be backflow from the brachiocephalic. So if you have a brachiocephalic origin stenosis, no problem in that case. The second one will go, because the carotid is involved, the second limb will go and make an anastomosis to the left common carotid.
Okay.
So you protected the brachiocephalic, you protected the left carotid, both are supplied from the ascending aorta. So it is a 10 millimeter, you can take a 8 millimeter graft as a side branch, which you will connect into the left CCA. Sometimes we do a carotid subclavian bypass also, if subclavian is also involved.
Yes, subclavian is also. So one more thing, so that there is like 13 mm brachiocephalic size. So what size, which graft we need to 13 mm? Healthy brachiocephalic is 13 mm, otherwise 7 mm. Stenosis area is 7 mm. So which graft, which size we recommend? 13 mm or 16 mm, 15 mm for bypass?
No, bypass we do 10 to 12. That's all. We don't take a bigger 10 to 12. That's what. The major limb will be 10 to 12. The side limb, if you are going into the carotid, we take 8 to 10.
Okay.
Yeah.
Thank you very much.
That's all?
Yes, sir. Thank you very much.
Satya?
Thank you very
Yeah,
much.
Satya, that's all?
Yeah, think that's all. Can I ask like one last question, sir? A little more a general one, a basic one. Sir,
Yes,
like
please.
this is one therapy where we see that there are multiple specialties, like who does the the treatment,
Yes.
the ICs, IRs,
Yes.
and vascular surgeons. Like so many, we don't see
Yes.
like this sort of like sharing in many other therapies. So, what is the normal referral pathway?
See, first of all, the more the merrier. So more people are there, that is good, no doubt.
Okay.
And more the competition, the best person, the best operator will always survive to do the best possible work.
Right.
Now, because if I'm doing a endovascular aortic repair, then the cardiologist looks at it, the cardiothoracic surgeon is looking at me, and the vascular surgeon is looking at me. So I have much less margin of error. I should know where is my anterospinal artery and where is my internal iliac artery, and if required, I should be able to cannulate each and every vessel. And if required, I should be able to do a percutaneous injection of glue. I should be able to handle those material.
Right.
So we need a person who has the ability to perform precisely and manage a complication if it comes. So there is no problem. There are more people. That's fantastic. No problem.
Okay.
Ultimately, it boils down to whoever is the best operator, patient comes to them, and that's how the therapy grows. Being said that, the referral pattern is most of the patients I get it from general physicians.
Okay.
Most of them.
Okay.
Yes. And second thing is that because I do a lot of CME, I invite a lot of GPs and all this, and we just discuss about it. I just did a IoT summit about December, just before the COVID.
Right.
We invite people, we speak about the aortic endovascular therapy for aneurysms and all. So, people get aware, and, once in a while they come across with such disease, and then they refer to us.
Okay.
That's how we have been doing the largest number in this particular region.
But then general physician doesn't diagnose it. They're only seeing the general symptoms, right, sir?
No, they just do an abdominal ultrasound for many of the things. They pick up a disease.
Oh, okay. Okay. So it's
Yes.
being picked up at their level, right?
Yes, because they do ultrasound abdomen for many things. Just you go to a GP, they will just do ultrasound abdomen.
Correct. Correct.
Just like that. There might be something which is nothing wrong.
Okay.
There might be something wrong. Look at the liver, the fatty infiltration. Look at the spleen. Look at every organs, little grossly. Kidneys are fine or not. So in that process, they just see there is an aneurysm. That's how.
So the scan centers plays a major role in this, right? In the diagnosis.
Yes.
Right. Okay.
Yes. Ultrasound abdomen is has picked up many of the aneurysm that I have treated.
Right. Right.
Then we have gone for the other studies, all these Ct Angios and all these things.
Right. 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 Thanks a lot, sir. Like patiently answering all our questions. Is there any other question from the group?
Just a minute.
Yeah, I think there are no more questions from our side. Like, thanks a lot, sir. Like,
fantastic.
Right.
Thank you very much. Thank you.
Right. Really
Thank you, sir.
Thank you very much, sir.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
I'll close the meeting. Thank you.